Thank you all. We had a great, powerful panel, and there are some questions, and I'm going to backpedal to some of the questions that were asked during the prior panel. There was a quick question on, does any of the research unpack and disaggregate Asian and Arab, Asian, Native, Hawaiian, Pacific Islander identity groups or categories, given the considerable social, economic, and other inequities, differentials, and disparities that exist within and across these ethno-racial subpopulations? The quick answer is this is a big challenge. It's a challenge for Latinx populations. It's a challenge for indigenous populations. It's a challenge for all populations. Because I will tell you, when you start to do a deep dive into the data and they don't really exist, it's really hard. So there's a lot of work that needs to be done with this, because even within Latinx populations, Puerto Ricans, for example, Puerto Rico data for maternal mortality are much worse than Mexicanos, like myself here in the United States. And so we really need to unpack these, because that helps us get to the more important on the ground work that needs to be done to really center birthing persons and give care that they need, and center them in that care, as was said so well in the last several sessions. Someone asked, I'm especially intrigued and interested in the notion of midwifery model of care. Data say that Black women in the UK, where midwifery is the standard, actually do worse than Black women in the United States. How does that reckon with significantly less diverse midwifery workforce in the United States as a solution? Who would like to take that question on? And it could be from the panelists and the prior as well.
So I would like to comment on the previous question, and that is that in the Giving Voice to Mother study and in our current Respect study, we do ask much more detail about what type of Latinx or what type, if you say you're Black, or you say you're mixed, people could self-identify in many ways, and we did collect data on specific categories like Hawaiian natives, or whether you are Puerto Rican or from the Dominican. That's another whole, how people self-identify is an important thing that needs to inform the census categories and how we go forward with disaggregating data and really represent people's identity. As you said, Dr. Simon, that it is, you can't just put people in. An Asian, as a South Asian person, I'll say, I'm often lumped in with many other types of people who come from a very, very big, continental landmass, and very different outcomes and cultures and whatnot. So it's not okay to just use Asian. So we did do that but then if you don't have enough participation, or you don't have the backing of a national study and the funding, you can't get a representative sample, big enough numbers in any one of those cohorts, right? So I think we could describe, if I had help from any of you, about what it looks like, how people in the US are self-identifying, but then going back to the funders to understand how we can do studies that really capture more information from each subpopulation. I just wanted to add to that it's possible. It's just, and we have a model for it. It's just, complex. And I am a midwife, so I guess I'll try and help with that other question. And I am a midwife of color, and I will say that I, throughout my practice in the U.S. for 25 years, was sought out because I was the only provider of color there, not because my clients were South Asian, they were Black, they were Latinx, but they felt that they perhaps that was an option for something that was more culturally safe. And I think there is certainly a big problem with not having a diverse workforce across the board. That's definitely an issue in the US and Canada as well. And we know that racism and the lack of acknowledgement of racism exists in professions that are purported to be better at things like autonomy and respect, or have more relationship-based care. So that's been documented. I don't think, though, in our analyses that it's still true that all autonomy and respect and relationship-based care and prevention and informed decision-making is better. So within midwifery population, there are differences by race, but all of midwifery care still appears to be more responsive in that way. And it's not that midwives are mad, it's the model of care, right? It's the time that's afforded. It's the approach to informed decision-making. It's person-centered decision-making and care. So I think that could be taught to all professions, and that's possible. But certainly diversifying the workforce should be an absolute priority.
Thank you very much. I am actually, before I transition to my next panel that I'm moderating, I really want to think about considering the life course perspective. And I don't want this pandemic to go to waste, so to speak, with what we can do moving forward. And so I'm wondering if our current panelists can give a brief 1-minute soundbite on what impact do we expect to see moving forward? What's the most impactful thing that we can do now that we've learned during this experience and all the wonderful data that each of you are showing? What can we do moving forward? What's one tidbit, one thing? Each of you, Dr. God, Ms. Mitchell, and Dr. Bryant.
I would say for me, it is just centering the voice of the patient. I think or for us in the clinical space, is centering the voice of the patient and not prioritizing or claiming to prioritize safety over sort of that that feeling of equity and valuing who the patient is. So that is something that I have learned, I think, myself in this pandemic.
I would say listen to and trust Black women, Black people, and the birth workers that provide them with care. Telehealth is a tool. However, it doesn't remedy or fix poor quality care or lack of access. If anything, introduction of new technology only exacerbates existing inequities.
And I think for me, I think that the attention to maternal health and reproductive populations has, at least from my perspective, been more pronounced during COVID-19 and has caught the attention of the lay media more than in prior epidemics and issues that have disproportionately affected this population. So I think kind of keeping that momentum going, advocating for inclusion of pregnant and lactating people in studies of all kinds. I think we need to keep the momentum going.
Thank you each. Really, it's been a fabulous thing. One thing that just blows my mind before I transition is that we saw in this pandemic that when communities and people come up with their own strategies to solve the issue at hand, they actually have the right answer. And what I don't understand is why we as academics, healthcare providers, policymakers, public health professionals can't always see that we can't trust that the community knows the answer and so it has to be hyper local. We see this in vaccination uptake, right? So it just blows my mind that we can't switch the thinking, the mindset